So prosthetic joint infections remain among the most devastating complication in orthopedic surgery. They have increased incidence that actually parallel the growth of the enormous amount of procedure that now have been undertaken for this purpose. While treatment protocols are well established, the evidence supporting current approaches is lacking, and the outcomes remain suboptimal, highlighting the need for improved therapeutic strategies. AAC recently published a very, very comprehensive review of randomized controlled clinical trials and emerging evidence for the management of these difficult to treat infections. Today, we will discuss this paper with one of the main authors and an expert on this type of infections. So, welcome to Editors in Conversations. The objectives of the podcast is to review the challenges of treating prosthetic joint infections, discuss major clinical trial data supporting different approaches for the treatment of these infections, and provide some guidance as we discuss these trials of what is being done for these infections. This episode is brought to you by Antimicrobial Agents and Chemotherapy Journal, available at asm.org/AAC. I'm your host, Cesar Arias. I'm the editor-in-chief of AAC, and this podcast is supported by the American Society for Microbiology, which publishes in AAC. If you plan to publish in AAC and if you become a member of ASM, you get almost up to 50% in publishing fees discount. Visit asm.org/membership to sign up. And don't forget to check our latest issue with fantastic papers on pharmacology, mechanism of resistance, clinical therapeutics, among others. We have special sections now dedicated to clinical cases and new perspective antimicrobial agents, and now a stewardship, specifically very well curated papers there. And I just want to continue with this announcement because this is very important that for the first time in many years, the American Society for Microbiology and the Infectious Disease Society for America are excited now to announce a new meeting that is called IMARI, Interdisciplinary Meeting on Antimicrobial Resistance and Innovation, that is going to take place in January 28 to the 30 in Las Vegas. I have the honor to be the chair of this meeting. The program is fantastic. There's still time to sign up. Abstract deadline, unfortunately, is over, but we have phenomenal response in abstract. So check the fantastic and really awesome program where our community is back together at imari.org. Okay, with that, I want to introduce our guests, a very distinguished guest for discussion of this podcast. The first is Professor David Paterson, who needs no introduction, but I still have to introduce him. He is a professor at the National University of Singapore, who has joint appointment in two of the School of Public Health of the university, and is director of the Advanced ID Group. And Dr. Ana Victoria Salas Vargas, who is assistant professor of clinical medicine at Houston Methodist Academic Institute and Weill Cornell Medical College in New York. Welcome to the show.
Thank you so much.
Thanks for having us. And Cesar, I do need to make a declaration, a disclosure, because managing prosthetic joint infections actually allowed me to put both of my sons through private school and college. So for ID guys and girls, it can be, a major source of billing,
of course,
and of difficulty. And I think that's why it's really fun to have today's podcast on this topic.
Well, thank you for sharing that. Dr. Ana Salas is taking notes about this very much.
Yes.
So, okay, so let's get into this material. So, Ana is you're an ID doc in a hospital, very complex hospital in Houston, Texas. And you specialize in these musculoskeletal infections, particularly these prosthetic joint infections. So in your day-to-day, what would you say are the major challenges that you face when you approach this patient with prosthetic joint infections?
Yes, I mean, the question as well is why these infections are so hard to treat, right? So number one, I will say, many of the bacteria that can cause prosthetic joint infection usually have the ability to develop biofilms. And these biofilms are actually, like a protective shield for the microorganisms against the immune system and the antibiotic effect. So that's one problem that we face. Many times the antibiotics are not going to be, effective against these infections. The other point is that we are dealing these days with a vast diversity of microorganisms causing infection, including multi-resistant microorganisms like MRSA, VRE, multi-drug resistant gram-negative bacteria, and even fungi. Let's talk about, obviously Candidosoma auris, which is, very difficult to treat. And the medical treatment as well will depend 100% on the surgical management as well. And these patients require a very, extensive multidisciplinary approach. I used to say, one algorithm or one protocol usually doesn't fit all the cases that we see. So, as well, we have a lot of, debate about the management of these patients in prevention, duration of treatment, route of antibiotics. With Oviva trial, we knew that oral antibiotics are, as effective or no inferior to IV antibiotics, but still, is a debate, right? IV PO antibiotics, what happens if a patient cannot receive rifampin as part of the initial treatment, duration, the need for suppressive antibiotic treatment. And like you mentioned, we don't have like a strong evidence based on high quality randomized control trials to support the current practices.
Yeah, perfect. This is a perfect segue. David, since you have treated orthopedic infections, and your family is very grateful for that in 3 countries: United States, Australia, and now in Singapore. Anything to add about the challenges with these infections?
No, I think what Anna said was spot on. And, normally for ID people, it's drug versus bug, in the presence of the ID physician and the patient. But here we have this sort of 5th domain, the surgeon, and that creates an awful lot of complexity because I'm convinced that surgical technique and surgical approaches to the management of prosthetic joint infection play a really big part in the eventual outcome. I remember a particular surgeon, and I knew if he was going to do a DARE, a debridement and implant retention, the patient was going to relapse. For some reason, he was a great surgeon at doing the prostheses, but unfortunately, he just didn't really know how to do infected joints. And this is a big challenge for us, both in clinical practice, but also in research as well, because we have that additional domain. And I don't want to be negative to our colleagues, our surgical colleagues, because they are fantastic. And those who do a lot of infected joints can be brilliant. And I think Anna sort of mentioned this concept of like a multidisciplinary team approach. And I think that's the most successful units have that, rather than it just be, the ID person is consulted and the surgeon, leads the charge, sort of thing.
And this is this is like going into marriage. You want to have a chemistry with the surgeon, and if you don't have that chemistry, it's a fantastic interaction. If you don't, it's a complete nightmare, right? That's that. Okay, so in that beautiful paper that you wrote with your colleagues, updating us on what's going on and the challenges. One of the first trials was this roadmap. So tell us about this trial and what you learn about it, and then we let Anna to say how useful would that be for her.
Yeah, no, it's really interesting the way that clinical trials are changing, and when I say clinical trials, I mean investigator-initiated trials. In other words, driven by clinicians instead of pharmaceutical companies. And one thing that seems to have been a really major advance is this concept of platform trials. And just to explain that a little bit better, imagine if you were organizing a football competition, and for each game, you built the stadium, you played the game, and then you destroyed the stadium, or you just left it. Nothing more would happen in it. And that's what normally happens with clinical trials. We do all the feasibility, we design the protocol, we do the trial, and then it's over. But the concept with a platform trial is you build a stadium, and you can play multiple games in that stadium. And in fact, often the idea for a platform trial is that they are perpetual. The games will just keep on playing. And so an example that a lot of us have heard about is this SNAP trial, which is a Staph aureus bacteremia platform trial. And now in the gram-negative fields, there's Balance Plus, there's Treat GNB. So things are happening in ID with these platform trials. And they're a lot more efficient in that we don't just destroy the stadium, we keep it going, we keep the infrastructure going. So Roadmap is like that for prosthetic joint infections. So there are at the moment 4 games being played, 4 trials within this platform. And the first one addresses a perennial sort of question: should we add rifampin or not? Because, as Anna said, biofilms are essential, but there's been a lot of dogma and even guidelines created from very, very small pieces of actual patient evidence. So, that's one. Does rifampin truly make a difference? A second one is, you've done a 2-stage procedure. So just to go back a step, with prosthetic joint infections, they can be approached in a number of different surgical ways. We could clean everything up, but leave the implant in. That's called a DARE, debridement and implant retention. We can take it all out and in the same surgery put the new prosthesis in. That's a 1-stage. Or we can take out all the dirty stuff, give antibiotics for a period of time, and then put the implant back in. That's a 2-stage. So the second game, the second trial within Roadmap is, after you've done the 2-stage, do you need antibiotics or not? Do you need sort of an antibiotic chaser? The third one is, if you do it all in one sitting, a 1-stage, how long afterwards do you need to give antibiotics? 6 weeks or 12 weeks? And then the fourth game, the fourth trial, is really a surgical strategy trial. If you've got what's called late acute PJI, what is the surgical strategy? Can you still leave the implant in and do a DARE, or do you have to remove everything and do a multi-stage replacement? So 4 different games being played. I think many of us as clinicians could think of lots of other clinical questions that might be able to be trialed within this platform in the future.
Yeah. Anna, what is your reaction about, imagine that all these games go to and I'm talking about football, soccer, to the 90 minutes, which is what the game I play, and then you have an answer. How useful would that be for you treating your patients?
Well, I'm definitely super excited about this trial because it specifically pinpoint the 4 major questions that we always have. So, for example, the first point, about the late acute infection, we are doing theirs as well here more frequently than 2-stage. So that will be very helpful, if we can avoid the patients to have a second procedure, right? The use of rifampin, at this point in time, we are using it, but as we know, there are many, many interactions with other medications that the patients take, and many of them cannot tolerate it for long periods of time. So that will be extremely helpful as well. Many orthopedic doctors prefer to suppress after a two-stage revision or exchange. And I do believe, that sometimes we treat a lot, too many days, too many months, and maybe it's not necessary. That will decrease as well side effects of the antibiotics. Patients will be definitely more satisfied if they can, receive only, let's say, 30 days instead of 3 months after a revision. So that will be extremely helpful.
So
How about my billing? How about my billing, Anna? If we're shortening antibiotics, I have less billing. But sorry, of course,
that would be a
patients have
potential problem.
But
patients have to come
I'm
number
super
one.
excited waiting for the results. Yes, absolutely.
So David, have they released any results in a meeting and anywhere? Or
no, not yet. It's started to enroll, and you can imagine, building a multi-purpose stadium like this is a big undertaking, but they got it up and running pretty quickly. It's going to be multi-country, Australia, New Zealand, UK, Canada. One of the challenges, of course, with a big clinician-initiated trial is how to get the money to do it. And, I'm sure it would be great to have more countries on board, but they have to sort of find the funds to be able to do it. And that's sort of part of the issue. So no results yet, but stay tuned. There should be something really interesting coming from this.
Let's move on to Solario, David. Tell us about what Solario is.
Yeah, so this is really interesting because this was a trial done in the UK. And one of the things about bone and joint infections is the action is all local. Of course, some patients have Staph aureus bacteremia and cedar joint, but most of the time, the action is all local. So in this trial, people routinely had antibiotic impregnated cement or spaces. So it was, there was local antibiotic therapy occurring. And then they randomized people to either less than 7 days or greater than 4 weeks. So, really to challenge dogma that we need to go for a long, long time with systemic therapy if you've got local antibiotics in there. Now, they did exclude debridement with implant retention. And the other thing is this has only been presented in abstract form so far. It did seem that the patients who got the short course, along with the local antibiotics, did just as well and had fewer adverse events. But with all of these sorts of trials, I think sometimes we've been a little bit burnt just going by an abstract without seeing the full paper and all of the details. So this is a pretty gutsy sort of concept to, okay, we're going to keep it super short. We're just going to almost be imagining that the local antibiotics are doing all the heavy lifting for us.
And then does it make you anxious, that short course?
Yeah. That's always the thing. Like the Oviva trial and, the POET endocarditis trial, I think when trials really challenge our dogma and the way we've always done things, it takes a lot to turn our practice to go with the evidence. And sometimes we can come up with all sorts of excuses why for our patient that they shouldn't follow the trial results. But in general, RCTs are the top level of evidence. And, my opinion is we should go with the best quality evidence. Although maybe politically that's not always the way things are done in some countries in the world. Sorry.
Yes, that happens. Anna, what is your reaction to this?
Well, number one, like you mentioned, there is not included, right? So that's a little caveat on the study. But, if you are, receiving local antibiotics, include, here in Houston, Dr. Incabo, he used to administer intraosseous vancomycin for arthroplasties. So that local antibiotics definitely play a significant role in the control of these infections, I believe. We need data. And yes, I mean, maybe 7 days will be really short, but we will see the data. I will not be against that.
Okay.
And it's interesting, there are a number of companies that are also going with this local approach, because I think everyone's aware that the systemic antibiotic market, it's a hard place for companies to make any money for a variety of reasons, stewardship and poor reimbursement, etc. But sort of using an orthopedic device approach, so, having either putting peptides in locally or potentially phages in locally, or some other delivery device to administer conventional antibiotics locally. There are a number of companies looking at that. So it even though I know ID people have often sort of been a bit down on topical antibiotics or local antibiotic administration, maybe we've been a bit wrong on that, really.
Yeah, and I think if there is a way to succeed is in those type of infections potentially, including, I've been very skeptical of certain approaches, but I think this is an area where there is a chance, I think, to succeed. Okay, let's move to another trial, Ricotta trial.
Yeah, I guess one of the things about doing clinical trials is you've always got to come up with an interesting name.
Yeah, this is an interesting name.
That's right, and I guess you get bonus points if it relates also to the topic. In this case, ricotta's got nothing to do with prosthetic joint infection, but the RI is rifampin, I think. So this is again, does the use of a biofilm active antibiotic combination really make a difference? And so they have randomized people to rifampin plus levofloxacin versus clindamycin. So clindamycin, as far as I know, doesn't really have biofilm activity. Rifampin and levo both do. It's interesting, in some parts of the world, there's resistance, certainly to levo in Staph aureus or coagneg staphs. But this is being done in the Netherlands, which is a country where there seems to be no resistance to anything.
Correct.
So an interesting approach. But again, getting back to the biofilm, what is the biofilm the crucial element here in the management of these infections?
Yeah, interesting here in the United States, we have a higher proportion of Staph aureus resistant to levofloxacin. So, Anna, what is your reaction to this trial? How useful would be?
Well, because, still we can use other antibiotics instead of levofloxacin. Actually, the protocol as well allows to use, Bactrim will be in our, here in the United States, or tetracyclines. So maybe that will be more applicable to the United States, comparing rifampin, Bactrim, or doxycycline combination versus monotherapy. That's the question, right? I mean, is monotherapy equal or not inferior to the combination with rifampin? So we still can extrapolate the results. One thing that keep my attention is that they are using high doses of levofloxacin, right? Like 500 milligrams twice a day is high, and as well the rifampin is 450 twice a day as well. That those look like the higher doses than the ones that we use daily, right?
It's interesting that higher dose, Europe and Australia, they I mean, people get a little bit anxious more than 600 a day of revamping here in the United States for reasons that I know. So when I try to use the 450, people look at me and my pharmacist, what are you doing? So, and I think we still have a lot to learn about how to use it.
Mhm.
So the next trial is also related with one of the rifaximines, actually. It's called RifaMap. Okay. So what is that about, David?
Yeah, so again, the name says it all. This is comparing two rifamycin, so rifampin, our old favorite, and oral rifabutin. You know, we've used rifabutin in the AIDS era for MAC. It's interesting, actually, just slightly off topic, that an intravenous formulation of rifabutin has now been developed and is going into phase 3 trials for Acinetobacter, which is, you know, it's obviously an antibiotic, or that class, the rifamycins. There's a lot of interesting things about them that perhaps we don't really know. But the concept in this trial is that rifabutin will have less drug-drug interactions, less adverse events than rifampin, but still be able to get into the biofilm and have activity. And I do think all of us have used rifampin, you know, in the old days when we had people on warfarin, you know, the huge doses of warfarin you were suddenly on, and then the fear, what, you know, when we stop the rifampin, how are we going to get them back onto the, you know, the right anticoagulant dose? And similarly in our transplant patients, you know, with tacrolimus and cyclosporin, I've got a little secret to tell. Sometimes if the transplant surgeons would refuse to stop the immunosuppression, I added rifampin for synergy, meaning I
That's
was
very clever.
trying to actually pharmacologically drop their immunosuppression without getting into a huge fight with the surgeon. Whoops, I shouldn't have said that. But it is, you know, rifampin is a wonderful drug, but it's not that easy to use, and things like pain relief and all sorts of things it can play havoc with. So the concept is, you know, can rifabutin take that place of rifampin?
So Anna, so what do you think about rifabutin here in the United States? Since we don't use it very much, except for, you know, very occasional, particularly HIV/AIDS and things that we're trying in treatment, you know, tuberculosis of no tuberculous mycobacteria potentially. What are your thoughts on that?
Well, personally, I have not been using rifabutin instead of rifampin for prosthetic joint infections, right? But it will be, if we can prove this, it will be very helpful for the patients, exactly, because, you know, the majority of them have multiple comorbidities, interactions, you know, with anticoagulation, cardiac, antiarrhythmics, just name it, right, the interactions, and looking for a better profile in with respect of interactions and side effects. So that will be as well important to have the answers on that. But maybe, you know, we don't even need the rifampin, you know, combination.
And that's what I was going to tell you. You know, I guess it would be interesting to see the results of the platform trials and when the rifampin is being used. Is it really when to use rifampin? I agree with you, David. I mean, this is such a good drug when you can use it, and in combination is really potent for this type of infections. But maybe we are getting too much of it, or just when we think about it, there's a lot of difficulties because of the interactions. I mean, we may need to simplify it, and certain patients potentially do well with this.
But it is tricky because, you know, the science, and as Anna said at the beginning, you know, biofilms are a big part of prosthetic joint infection. So, you know, the science would say, well, if you can hit the biofilm, that should help us. But I guess there are many examples where what we thought was the truth based on on in vitro or mechanistic action. When it comes to clinical trials, it doesn't pan out. So I know there are some people who are absolutely insistent that it's negligence if you don't use a antibiofilm acting agent. But I do think in the absence of really decent sized clinical trials, we have to sort of have equipoise and let's wait and see. And I can imagine there are going to be some people who are not going to participate in anything where you're not going to get a rifamycin or a biofilm active antibiotic because they're just such strong believers.
Another situation with the biofilm is if you have a very extensive debridement, that's crucial as well to try to control or cure this infection. So they go together.
Yeah.
And I just want
to... Sorry, Cesar, you go.
No. Please go ahead.
Oh, yeah. I mean, that's where, my colleague, the surgeon, who I knew always his patients were going to fail, I'm convinced he just didn't do an adequate enough debridement. And, I think that's another reason why you can't do a DARE arthroscopically, because you can't get in there and clean everything properly. And, there are some removable bits that you can take out and put a clean one in, and you can't do that arthroscopically. And if you don't have good surgical technique, you're not going to be able to do it.
Arthroscopic debridement is a risk factor for recurrence anyway, failure at one, year, even shorter time.
Yeah. But, there is another element, which is, and I love the basic science, that it is sometimes very difficult to assume that all the microorganisms are going to behave the same in the same biological need. And this is something that I have sometimes arguments with the people who, I understand that a clinical trial is a higher level of evidence, but it's very difficult for me to say that the Staph aureus that is infecting your knee is the same Staph aureus that is infecting your other knee and the other patient, even if they're genetically related, because there are so many other factors. So I think it's important to take both clinical, preclinical data all into consideration when you make a decision, and not dismiss one or the other because you are, in one side or another. I know that we live in a world that is now in one side or the other, but I like to be centrist.
No, I agree with you. And when, people make guidelines, or I like the term guidance actually better, particularly based on clinical trials, it is just guidance. There are going to be individual situations for which we need to diverge from that. And I do worry a bit when we are potentially penalized for not following guidance, or, whether it's, and it's a truth about stewardship, whether it's antibiotic stewardship or diagnostic stewardship. Sometimes we get into fights with our own teams because, no, I'm not going to stop at 7 days, even though the big trial said 7 days for bacteremia was just as good as 14. There are things about this patient that sometimes non-clinicians don't understand because there are some complexities. It is tricky, though, because some opponents of stewardship have always said, all of my patients don't follow the trials. They're all unique. And those people are hard to deal with.
That's the best excuse always. Okay, let's move on to the option trial, David. That's more a sort of a surgical trial.
Yeah, so it's really 1 stage versus 2 stage. It's interesting geographically. There are differences in approaches, and I have to say, when I've practiced in Australia, 1 stage is almost never done. It's almost always 2 stage. And, the concept with 2 stage is you get the badness out, you give antibiotics to clean up any germs that are still left, and then you put the new prosthesis into what should be a beautiful, clean field. But I think there are a lot of results that have shown, well, two-stage doesn't actually get better results than one stage. Now, some of that data is not perfect. So the one stage, again, is you take out the infected joint, you clean everything up, but you put a new prosthesis in there and there. And so obviously from the patient's perspective, having just a single operation is much more preferable. And that period of time between the explant and the implant is a pretty miserable time for patients because they don't have a functional joint and they're wheelchair bound or hopping around on crutches. I had a knee operation recently, just a arthroscopic one, but I had to go on crutches. My wife said I was like Bambi on ice. She didn't. She was waiting for me to
Believe me, I have one joint that needs some operation, and they say 6 weeks in crutches. They say, physical therapy, I think.
but it is a miserable time, patient, when
yeah.
you really are not functional. And so I think it is a big question. It's interesting, Anna, what is the practice in Texas? Do you see one stage more frequent than two stage?
Well, when we are dealing with, late infection or symptoms for more than, let's say, a couple of weeks, the standard of care here for chronic and delay infection is two-stage.
Yeah.
That's the standard of care. But more and more, we are seeing what we call 1.5 stage exchange. The orthopedic doctors do this, especially in people who are not very mobile. Let's say you're not going to run a marathon like in 2 months, right? So maybe you will be a candidate for this. And they leave the spacer, which usually is an articulated spacer. They leave it there for long periods of time. Months, and some people, they are pretty functional, but like I mentioned, if you are pretty active physically, that will not be a good option for you. In that case, what they do is the two-stage, absolutely, with the symptoms, like late infection. When it's early, let's say after surgery, in the first 3 months after surgery, they will consider there. Or if you have a bacteremia and it's an acute hematogenous prosthetic joint infection, we do there. But for the rest, is more, two-stage. Mm-hmm.
So it's interesting that the 1.5 stage you mentioned. So in Australia, we call that a kiwi. Do you call that a kiwi in the US?
No,
absolutely not.
I don't know why we call that a kiwi procedure, but
that sounds like New Zealander.
That's right, exactly. Whether it was a New Zealand surgeon did it, I don't know. And of course, the other, the other management is sometimes we do have people on long-term suppressive antibiotics who we just feel cannot tolerate. Mm-hmm. And we often do it in, quite elderly people with lots of comorbidities. But it does get a bit embarrassing when, 10 years later, they've been coming to clinic for 10 years on suppressive therapy because we thought they, wouldn't survive the operation. And meanwhile, they keep on going.
Yeah, absolutely. So the last trial we want to discuss, this is the cute name, and I love dogs, is the Corgi trial.
Yeah, and I'll have to go back and see what the letters stand for, but O most likely stands for amatocycline. So this is a drug trial, and it is difficult. And if I was, a drug developer, actually, I'm trying to think whether any, daptomycin or anything, I doubt that any of them have actually got a label, an FDA label for prosthetic joint infection, because with these big issues with source control, with the surgical variable and having to involve long courses of therapy, etc. These are tough trials to do, but this Corgi trial really looks at omadacycline, which I presume will have some biofilm activity as well. Anna, do you know that for sure, whether omadacycline, I think it does have some biofilm
Yeah, there is some
activity.
empirical data that published in our journal several years ago about that
Right.
possibility. This is a drug that has become a go-to in the Mycobacterium abscessus infection for us, and as part of combination therapy. It's interesting to think about that drug for prosthetic joint infection as an oral option.
Yeah, yeah.
Anna, any comments on that?
Yes, well, actually, by coincidence, I requested today pre-authorization and approval for this drug in a patient that I have with VRE, effusion, periprosthetic joint infection, who has not been tolerating eravacycline. This based on susceptibilities, and now she had a significant increase in the CPK due to the aptomizing, right, the high doses that we need. So I'm requesting that for her. In combination therapy and most likely chronic suppressive treatment, because I don't have any other options. And we will see, but the situation, in the trial, the only thing is that, few cases were included with prosthetic joint infections. They analyze more in general, right, bone joint infections and very few cases of prosthetic joints. So I'm not sure how much will be helpful, but if we can prove some benefit, benefit of the treatment, we could use it, especially for, like I mentioned before, multi-drug resistant bacteria. It still could be one possibility that we have for our patients.
It's
Here,
interesting.
the cost, we need to go through, insurance approval and everything for this drug. So it's kind of a little bit complicated to have it, but in some instances, I will use it when I don't have any other options because
It
of
is
the microorganism
interesting.
resistance.
Yeah, it's interesting, Anna, when you talk about these really resistant organisms. I mean, VRE is one, but sometimes the resistant gram negatives, and even Pseudomonas. If you've lost Cipro, you're in trouble, and Acinetobacter and others. It's interesting for us to think about locally delivered phage therapy, and I know there are people doing that around the world in France and in various other countries. Have you had experience or had ever to use phage therapy when there were no antibiotic options at all?
Not yet.
No, it's tricky, and of course the ultimate there are many bad outcomes, but I've had some situations where, because of a multi-resistant organism, the patient needed an above-knee amputation. And,
absolutely,
this is an absolute tragedy. You go in thinking you'll be able to walk without pain. You get an infection and you spend a miserable 9 months in hospital with all sorts of PICC lines and complications, and then you end up with an above-knee amputation. This is...
Yeah.
We do need new options. And I guess the other thing is, even with our gold standard therapies at the moment, it's hard to aggregate results, but probably 20 or 30% of people will fail. I don't know, is that a bit negative overall in treatment of PJI, Anna?
You mean like
I hope it's... Well, overall, if you have a DARE or even a 1 or 2 stage, there's going to be a sizable percentage of people who do get a relapse or who do end up with a poor outcome.
Yes.
What that percentage is not clear to me, but it's substantial.
We have actually, it's not that high. The surgeons that we are working with, they are pretty aggressive. As far as I recall, during my time here in Methodist, which is 3 years almost, that happened with two only, right? One of them is because the hardware was completely exposed. And again, the failure sometimes is because of infection is not controlled. But the other important situation to mention is how the patient is healing the coverage of the prosthesis as well, right? So that patient ended with amputation. And the other one, which I never will forget, a patient with Candidosima oris, multi-drug resistant. We even requested for fosmanogepix, which is one of the newest antifungals to treat this multi-drug resistant yeast. It took like 1 month for the medication to come here, but she had so many revisions that we didn't have any other option that above knee amputation. And then she developed a skin and soft tissue infection in the stump. But at that point, we have the fosmanogepix, we give it to her, and we save a higher level of amputation. Let's say this articulation, we didn't go to that road, thank God, and the new medications, right? But yes, it's definitely devastating, for the patients. Absolutely. Yeah.
Well, this has been a phenomenal and entertaining. I learned a lot of this conversation. Please go to this paper. There are other trials that we didn't have time to read about prevention of prosthetic joint infection, which is another really interesting topic that requires a kind of a different approach. But this mini review in AAC will allow to just get updated on this. And I just want to thank both of you for these very fantastic and useful comments on this. There are a lot of things to learn still, but we hope with all these trials in the next 3 to 5 years, we will have much more information on how to approach these infections that, as you have pointed out, are devastating for our patients. So thank you very much. This is Cesar Arias, Editor-in-Chief of AAC, signing off.
Thank you.